TopMedTalk.
Monty Mythen here. As we prepare to move into the next phase of the COVID crisis, we're going to be widening our focus here on TopMedTalk. We will continue to deliver COVID-specific programs, but we all have a huge additional responsibility as we try to reboot normal services. So although this piece is not directly related to COVID-19, we believe it's information that is crucial to the bigger task of rebuilding the healthcare system as we learn to adapt and live with this new virus. Thank you to our sponsors and to you, our listeners, for helping us to share this important information.
Well, hello, I'm Desiree Chappell, and this is TopMedTalk. We are live from the European Anesthesiology Congress, Euro Anesthesia 2019 in Vienna, and I'm here with Editor-in-Chief of TopMedTalk, Monty Mythen. Good morning, Monty.
Morning, Desiree.
And we'd like to thank Edwards Life Sciences, actually,
for sponsoring the space that we're occupying.
That's right.
Big shout out for them and to the ESA for allowing us to be here and snaffle people as they go past.
Snaffle. Wow, you're really with some of these words this weekend. I don't know. Well, anyway, so again, sitting down with some great people in our space of anesthesia and perioperative medicine. So our next guest, Monty, could you please introduce?
Well, we managed to grab an old friend. Yeah. He's not old. He's been a friend for a while. Yeah. Maurizio Cecconi. I hope I'm pronouncing it right, Maurizio. I've been working on that for years.
It's very good, actually.
It's the hard C's.
Now that I've left the UK, you do right.
Oh, I was going to come to that. Maurizio, I thought, was one of my colleagues in London at St George's Hospital, the UK. And then I got a message about 18 months ago. He said he's gone.
Now he's out of here?
Now his badge says Italy, which is like everyone's called Cecconi in Italy, aren't they?
Not everyone, but everyone knows how to pronounce it.
So what happened there, Maurizio? So congratulations. I know it's a fantastic move for you and the family, but
Thank you.
Tell us where you work now.
I work in Humanitas, which is a university at a hospital in Milan. It's a relatively young university and a relatively young hospital, so they have lots of projects or lots of ideas, and they are just hiring people basically to lead some of these projects. So yes, at the moment I'm having fun.
And in your title, I think you're both in anesthesia and critical care.
Anesthesia and intensive care, yes, both clinically and academically.
And you're the sort of chair, the director?
Yes, I'm the chair of the department there.
Both academically and clinical?
Correct.
Oh, so like it's referred to a North American style chair.
Yes, it's very similar setup. Yes.
Oh, great! Congratulations.
Yes.
How big's your department roughly?
We probably have around 80 anaesthetists intensivists. That we have a new school of anesthesia and intensive care that just opened. So we're going to have one full running. It will be 50 trainees, and then probably another 400 nurses and so.
Excellent. There's one other thing. You're the president-elect of the European Society of Intensive Care Medicine.
Yeah, correct. In my free time, I'm the president-elect of the European Society of Intensive Care Medicine. Yes, I was elected last year, and I'm very, very happy about it, yes.
Yeah, you're just trying to squeeze that one in, aren't you?
Yes.
Just one more thing. Well, Maurizio, you have several different things I think you've been working on recently and speak quite a bit. And you've been faculty here at this meeting. What were some of the things you were presenting on?
I was talking about patient safety with the European Society of Anesthesiology and ESICM, so it was a joint session. And I was talking about the future of intensive care, so even talking about how patients will look like in 2050.
Yeah, what's your... What do you see in the future here?
Well, you always think about the perspective about a patient in 2050. And actually, Monty said that I'm young. I'm relatively young, but in 2050 I could be an intensive care patient. So I thought, how I would like intensive care to be. And the reality is that the challenges that we have are probably population will get older. We know that. There's no mystery on that. There will be more comorbidities. That's the success of healthcare. Even the fact that we will see frail patients, probably more than what we see now. I do hope that we will see a change in preventing disease rather than just treating disease, but I'm not sure this revolution will start in the next 30 years. So we need to be prepared to more patients, more complex patients, but I do have hope. I'm doing now quite a bit of research and the work on getting people together, for instance, on working on big data and large data sets. And I do hope that actually that technology could help us a lot, maybe to tailor therapies better, because I think we're still far away in intensive care from precision medicine.
Yeah, the problem with big data is you can have all these numbers, but it's like, what do you actually do with
correct.
all of that? So
Correct.
are you kind of looking at the translation of some of those things?
I do, and actually one of the things I really enjoy doing at the moment is, for instance, doing courses with doctors and engineers and data scientists. So sometimes they are called datathon. You can call them however you want, really. The important thing is that you get...
A datathon?
Yes, so it's a marathon on data. MIT have been the pioneers on this, and they have these large data sets that they bring around the world. And the great thing about these meetings is that in 2 days you realize that data is not as complex as it seems.
Yeah.
And you can actually get your data, analyze your data, and exactly what you're saying, teach people that maybe at the bedside they can bring some of this to not just to look at data, but to do something with the data.
Yeah, it's so important. And it seems so overwhelming, but hopefully we're going to make this easier for people on the ground to be able to do it.
Everyone talks about artificial intelligence now.
Yeah.
It's a very sexy term. Everyone likes it. Of course, there is that, but I think it's exactly what you're saying. What do you do with the data? Maybe the larger concept of data science, I think, is what I prefer to refer to.
Yeah.
So starting from what is the clinical problem, what do we want to solve, how do we collect the data, collecting the data, analyzing the data. Artificial intelligence and full automation will probably come to, to fruibility at the bedside, but it's going to take some years. I think what we really need now is to get this data in a way that it's usable by clinicians, by nurses, by doctors. So I prefer to talk maybe about an augmented reality for clinicians in this sense. And I don't think we are far away from that.
Yeah, you see some augmented reality and some things even here in the trade exhibition. It's really interesting. Hopefully we can start adopting some new technology and using all this together. So I'm going to reveal something that I am so excited to be sitting down here with you two, because whenever I first got into the space of enhanced recovery and fluid therapy, the names that I saw all day long were, Mythen and Cecconi on all the literature that I started reading. And coming from a small community facility where I'm not in academics, like to be able to sit down with you guys now, it's pretty cool, I have to say. But fluids are kind of one of the things that you've been studying for a long time now and looking at and getting into that. So can you tell us where you are right now in that whole journey?
So, after some years of doing studies and reading all the studies of Monty, actually, because the thing is, he was he was the one really setting the pace there. Actually, I moved from trials and physiology to actually going back to the basics. And the more we do studies, the more I realize actually I know very little about what fluids do to us.
Yeah.
So I would say for the last 3 years we've done a lot of research on physiological outcomes, taking a step back and actually thinking, maybe I don't know what fluids do. And so we are looking, for instance, at fluid challenges, so small boluses of fluid in a short period of time. And we are taking fluids as if it was any other drug. And so we're doing pharmacodynamics and pharmacokinetic studies on this now. So looking at doses, times, the first effect of fluids, the sustained effect of fluids, and I'm getting actually pretty interesting data which is challenging my practice.
Yeah, can you share some of that?
Well, for instance, one of the studies we did recently, which I think is one of the ones that really prompted me to do more on this, was just giving a fluid challenge to patients, actually seeing the response, and you may hear quite a lot about fluid responsiveness.
Yes.
As if it was a yes and no mechanism.
Yeah.
You are either fluid responsive or not fluid responsive. And I would challenge that in a second, because what we found was that, yes, you have a group of patients that respond with an increase in stroke volume and cardiac output, another group that doesn't. But then if you look after 10 minutes, both groups, they were almost going back to baseline, which makes you think, what am I trying to achieve here? What am I testing? And I think we're learning more and more that really they are like any other drug. So you can see an initial effect, and then you're seeing what the body does to the drug as well. So, the sustainability of this effect is very interesting, and probably what matters the most to the effect of fluids when you give them.
Yeah.
Maurizio, is that predominantly being studied in the critically ill patient on a ventilator, or healthy volunteers, or the whole spectrum?
So it's a very good question, because we did this initial study, now we're repeating in different populations. This was in post-surgical intensive care patients. And one of the explanations that we have for seeing this effect of disappearing after 10 minutes, it could be that maybe patient didn't need fluids. I was not treated patient in shock. I was treating patients after they were already stabilized because I wanted to have a pretty reproducible baseline.
Yeah.
And maybe one of the lessons is, if your patient is well perfused, you can give fluids, but the body will probably disperse that because we don't need that extra venous return, we don't need that extra cardiac coupled and oxygen transport. That's one explanation, but there are more, and that's why we are doing more studies.
And how do you know they're well perfused? Because that's still the holy grail, isn't it? We're still looking very centrally.
We are, but I would say after surgery, and especially in a setup where we were doing goal-directed therapy after surgery and the type of surgery in which there was not significant blood loss in the operating room, probably I would argue that if the lactate is normal, the capillary refill time is fine, you may argue the perfusion is not as bad as you think. So just the fact that you're fluid responsive, as we know, does not mean that you need fluids and that you will keep these fluids.
Yeah. I know you've worked in the past, I think, with some of the microcirculatory measures, the STF camera under the tongue.
Yeah.
Have you looked at any of the renal stress markers? Have you had any experience with those yet?
We are doing some studies at the moment on the resistive index of the kidney. So basically it's looking at how pressure and the gradients in pressure around the kidney perfusions are working. And we have some interesting data that shows that maybe
How do you do that?
With ultrasounds.
Okay, cool.
So we can do that, and we are looking, for instance, if that is associated with postoperative complications. And interesting, it seems, but this is data that we've not published yet, so I'm just disclosing a bit here. It seems there is a signal there.
No one's listening. It's okay.
We can cut that out later.
So I hope Monty's forgotten about the statistical question.
All right, I'll keep on. Did you have any?
Yeah, mine was. We touched on this a little bit the other night. We're still, when we look at the big trials and when we look at regulatory approval and when we look at what is said to be the truth, it's the large, pragmatic, multi-center trial. It's a single high-level question at the top end, which is dichotomous.
Yeah.
And if you get the p-value the right side of 0.05, it's a win or a lose.
Yes.
Surely, and that's last century way of handling these things. I know there's a lot of discussion about Bayesian statistics, for example, but can't we do something with the whole big data thing? I mean, those people, they don't do that stats, do they?
We can, and we're already doing something about it. And I'm a big fan of big data. However, there is almost like these fights now, these gangs, clinical trials and physiologists and big data. And actually, I think the truth is a bit in the middle.
Yeah.
Because just to give you an example, which I always do when I talk about artificial intelligence and big data, Abraham Wald was a statistician in the Second World War that actually helped the Americans to win the Second World War because he was helping with the inspection of airplanes. So before him, all the airplanes that were coming down, they were inspected, and where the holes were, the engineers were putting extra steel.
Yes.
And what was happening, they were just making the airplanes heavier. And then he came along and said, you're completely wrong. You're just fixing the holes. They make not enough harm because the airplanes that got the real damage, they are not landing. So,
they landed before they got back.
Yes. So the point is, big data is great, but I'm not sure that we're collecting all the relevant data and all maybe the biological signals that are really affecting cause. And, so to move from association to causality, we still need trials. I hope that big data will join big trials, maybe to stratify populations so that we don't just put everyone in the mix.
So that was sort of my question. I wasn't making a point, was where big data meets big trial,
yes,
can we ask the right question in the right way and use an analysis methodology that isn't dependent on the primary outcome variable on a p of 0.05?
Yeah, I hope so. And I think there is a lot of hope now in phenotype stratification on data, and I think big data will be very powerful in this sense because the more data you have, which is what is in front of your eyes, so there's the phenotype that you're seeing, the more you can stratify the phenotype, and there's no doubt that I think computers can do that faster than human beings.
Well, Maurizio, we're running a little bit short on time, or wanting to wrap things up. But I do have a question. Monty and I have been talking a lot about the blood pressure story too, as well. And we've shown the POCI paper and talked a lot about the new POCI papers that have come out in the BJ in May.
Yep.
And so your name was on those too.
Yeah. Yeah, Monty invited me.
Yeah. Monty's like this wonderful diplomat and bringing everybody together at the
I think
table.
one of the others invited you, but I said it was a good idea. So
He'll take credit for it.
I'm more than happy to take the credit for it.
The paper is published now, I don't care.
Well, tell us about which one you were involved, because there were four different ones.
I was involved particularly in the physiology one.
Uh-huh.
So looking in regulation and why blood pressure is so important. Of course it is very important. Actually, I'm glad you asked that, because 20 years ago everything was a bit about maintaining blood pressure, but no one was doing anything about the flow. And then we moved to the area of goal-directed therapy, and we kind of forgotten a bit about the pressure, and I think they're equally important.
Yeah.
If I want to perfuse your organs, I need to bring enough oxygen, but I need to bring it also with enough perfusion pressure. Mm-hmm. So keeping two, I think, is going to be the next two standards in hemodynamics, saying, at least in the operating room, and of course in the intensive care.
And as you referred to, Maurizio, it's the pressure on the way in, which has got to be balanced by the back head of pressure on the way out.
Yeah, correct.
And then there's some stuff goes on in between, and the point at which each organ auto-regulates is different between organs and changes under conditions, which is...
Absolutely true. But very often we simplify this, I think, in the past by saying, patients are very different. Of course they're very different, but I think there is a lower threshold where there is enough evidence that probably you are going to auto-regulate very badly if you go below that.
And where's that map in the critically ill? Because in critically ill, it's not unusual for the right-sided pressure to be up, pushing to the 20s.
Yeah.
So you've got a map of 40.
Yes.
And you've got a CVP of 20. I'm not sure what's going on in between.
I'm not sure either, but it's not very good if you have those differences.
Which map are you...
I
we
would
won't
say...
hold you to it. We know there's no absolute answer here. But
No, there is no absolute answer, but as I say to my team, when you get a patient in shock, in those first 2 hours, it's not the moment to be very clever. It's the moment to do simple things in a reliable way. So I would say 65 is where I start, and then we can think about it.
Okay.
Yeah, that's a good answer.
Do we think the blood's getting to everywhere? And if it's not...
It may not be enough for everyone.
Okay.
It clearly may not be enough for everyone. And we have a lot of evidence of dysregulation of the microcirculation but really going back to the basics, I think is going to be very important. So with Glenn Hernandez and Jan Bakker, we recently published a paper on capillary refill time.
Yes.
Yeah.
Which is a very simple technique, but we found some very interesting results there. It was performing probably as good as lactate, I would say, even if the p-value was not really
I thought there was a suggestion it was slightly superior.
It was actually, if I have to be honest, the way I take the trial is that it is superior.
Cap refill.
The capillary refill time, so which basically you can, you can do it that way.
Squeeze your finger.
Yes, you don't need to buy a device.
Yeah.
It's
go feel
quite
the toes.
easy.
Yeah.
Quite easy, but it goes back to the bedside basically, and spending time with patients. And he was performing, at least as a trend, better than just looking at lactate measurements.
So I know we've got to wrap in a moment, but we encourage everyone to look at those 4 papers and the editorial published in the May edition of the British Journal of Anaesthesia, all about blood pressure. But the physiology one, there was no shortage of opinions in that group.
Oh, wow.
Oh, no.
So give us a few of the headline players there.
Well, it was Michael Pinsky, Gareth Ackland, the Jungings,
and et al.
Yes, but I was lucky because then you leave the things after a while and then you just write the paper the way you want. No, it's not true.
All right, so one more question, Monty.
You're
not going to get it. The statistics thing, you're not going to do?
I asked him the statistics thing.
I'm glad it was that.
I was like, well, you did great with that.
So the answer is there's no answer at the moment.
Okay.
I tried to give you an answer.
And we're stuck with the P of 0.05 for a while.
You know what? Actually, even statisticians now are saying we should move away from p-values.
Exactly. Yeah. Hence the Bayesian discussion.
Yes.
We still need to have a discussion about it, so you can explain it.
There's some great recent. Rupert Pierce did a there was the American Statistics Association. There was a letter that came out of Optimize 1, the Optimize trial, and said if you'd used Bayesian statistics as opposed to the classical dichotomous p-value, which reconsiders the data in different ways and likelihoods, it would have been a highly statistically significant result. So if you look on BMJ Open, if you use Pierce, P-E-A-R-S-E, Rupert R, Pierce R, as a way of searching it, you'll find a recent editorial about how Bayesian statistics give very different results to some of the trials. So you can turn clearly the p-value was 0.07, it didn't work, which is truly not the right answer. Especially
with these confidence intervals that sometimes are very wide. Yeah.
There's a very high likelihood that it did work, and we're in a strange space at the moment with that.
But we are actually reanalyzing some of our data ourselves.
And I believe the regulators. I was in an interesting meeting at one of the with one of the regulatory bodies. Let's say too much here.
Yeah.
In the last few years, and there was the discussion about the fact that you'd be allowed to submit to always have a secondary Bayesian analysis, not to necessarily get approval, but to say, hang on a second, I know you didn't cross the threshold, but it really looks likely that this thing probably worked, which will probably keep the investors interested in pushing on to get the answer to the question. Whereas if you get a p-value of 0.06, it often kills things off completely.
Yeah, not always, but it should if you are a believer of the standard statistics. And I think you pointed a very important thing. This new way of looking at things maybe brings some common sense back to how we analyze data.
So, Zana, we're going to wrap now, but because after this we're going down to... Are you going down to Prato, to the meeting?
I am not, unfortunately. I have other commitments. I would love to be there, but I unfortunately will not be able to join
this year. Wonderful meeting every 2 years.
Yes.
The clinical trialists in our space from around the world. There's a critical care meeting and a perioperative meeting. The perioperative meeting led by Professor Paul Miles from Monash. If you can get into the room, it's a wonderful place to be.
I know.
So we'll be hearing the late-breaking news and all the trials in the pipeline in that space.
Yeah, exciting stuff. Well, Maurizio, thank you so much for sitting down with us. It's been a real pleasure. Hopefully we can do this again and maybe dive some more in statistics.
And when do you start as president?
2020 in Madrid.
Oh, there we go. Wonderful.
Fantastic.
Excellent.
Well, congratulations on that and all the work you're doing. Thank you very much.
Thank you.
And look forward to chatting again soon. So thanks for listening.
TopMedTalk.
Just a quick reminder, subscribe to TopMedTalk. We're a daily source of news and conversation focused on perioperative care. We bring you all the latest talk from all the major conferences in the perioperative space. We can also be found on Twitter, Facebook, LinkedIn, Instagram, and we now have a free mailing list with special offers and additional goodies for subscribers. Go check us out at topmedtalk.com. That's www.topmedtalk.com.